After all this, you still want to be a sports cardiologist? Yeah? Okay, well, I must say I'm really proud to share the podium with, first time ever, with my teammates. Okay, that's the sports medicine physician and the athletic trainer. And our teams are a little bigger than that, right? And so I got to thinking about this when I had to edit the, I think it was the first sports cardiology publication for clinics in sports medicine, and I got a lot of people a heck of a lot smarter than myself to help out with it. So some great stuff there, and usually when you give a talk, it's a great opportunity to promote your own work, and make it seem like you sort of dominate the landscape of what's written about it, but it couldn't be further from the truth. And I think, though, that sports cardiology, Rich and I remember this early in congenital heart disease, we are now a discipline emerged. I mean, I don't think it's fair to dabble anymore, and I was a dabbler early in my career. I mean, I love sports. I've been in sports my entire life. I'd see a few athletes, but I really was part of the problem. I really didn't understand the difference between athletic remodeling and disease very well. And so I think we've really got to kick the can down the road a little bit further. And having said that, I feel like I'm but just a very small part of that team. And ideally that consists of an athletic trainer, a team physician, maybe a team nurse, exercise physiologist, really important. You heard about CPET here. And genetic counselor. Matt Thomas is here. I don't see Matt, but there's Matt back there. Been a great collaboration for me, and I've learned a ton about genetics by having a genetics counselor. And as a physician, you can't do that yourself. You just don't have the bandwidth of the time. And so since you are a specialist, it's going to be hard to get the at-bats, the exposure. It's not like going to the coronary care unit and seeing a bunch of sick patients every day. These people are few and far between. They're hard to find, and there's not really a lot of talk about that. So the other thing you got to be ready to do is you can't say, oh, I can see you 3 weeks from now. When it involves the heart and it's an athlete, you don't have a lot of time. I mean, on my way down here yesterday, one of our linemen had a syncope for the second time with peak exercise. He's a fourth-year D lineman, and so I was scrambling around to get the test done. Normally, I would have seen him yesterday, but I was on the way down here. But you just can't. You got to go quickly. So the athletic trainer and the team physician are the core of the sports medicine team. Now, the athletic trainer is the eyes and ears of the sports cardiologist out there at the training facility on the field and reliably reports on symptoms, comes to the visit with the athlete, can understand the plan, orchestrate the plan, make sure the plan is being delivered properly. Now, those of you who don't have athletic trainers, it's harder, isn't it? I mean, if you're working with high school kids or elementary school kids, it's kind of hard because you don't really have that control. And I'll say this also about trainers, and John, you should, when I got back to Charlotte, my son was playing baseball, Little League baseball, and I went down, and I'd heard one of my colleagues had donated an AED. Now, this was 10 years ago, to the Little League facility there, and I went and I couldn't find it. And I started knocking around. It was in the concession in a cupboard, stuck all the way in the back of the concession. We never would have found it if a kid had arrested. And that got me very worried. And then I went over to the training room that night, and I tried to get a photograph to simulate this for you, but I couldn't do it. About 30 athletic trainers in one room 10 years ago. And I said, okay, guys, how many of you know what commotio cordis is? Every hand went up without hesitation. And that kind of blew me away, and I learned last night that your football coach's twin son was killed when a ball struck him at the age of 7, and nobody knew what it was. And he wasn't resuscitated. So that gave me great peace to think those guys, if a lacrosse goalie gets hit with an underhanded jack shot and the kid goes down, they're not going to fool around thinking he's injured. They're going to get the AED out there and put it on there and get that rhythm strip immediately. So that was really reassuring to me, and so I can't emphasize how important that is, and they tend to be the ones. If you don't have a trainer, getting the kid to your clinic is not easy, trust me. And we also have, we've got everything from stethoscopes, blood pressure cuffs, a lot more tools. When I think back to 1975 in the training room, my trainer was a character. And when he finished that roll of athletic tape, he could snap it behind his back and hit the garbage can on the other side of the training room probably 9 out of 10 times. But he was nowhere near as sophisticated as what the trainers are today. So we've really made a lot of progress here, and it's also important, as John has shown us. I'm sorry I spelled your first name wrong there, John. and his partner Kim and my buddy Danny Mystery that you don't have to be a cardiologist to do really well at this. I've been learning from John for years. So we've got to kind of drop this academic arrogance that we have about certain things and be totally inclusive, and that's what I think is really great about this conference here today. So let's just go to a couple examples. So had a Division I volleyball player. She had classic symptoms of SVT. No, the vent monitors never worked. She couldn't wear them during practice. We could never catch anything, but I was convinced it was SVT. And this was before we had a lot of the gadgets that we have now. So I just said to the athletic trainer, and it always happened with activity, most of the time during games, I said, when she does it, get her out of there, put the stethoscope on her chest, listen, and tell me what you hear. Sure enough, boom, 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 boom. And so with just that evidence from SVT converting, we took her to the EP lab, mapped it out, and she was successfully ablated, never had another event. Now fast forward to this year, and we've got a swimmer. Same thing, convinced it's SVT, always in the water, can't seem to get the diagnosis. You're not going to wear an event monitor in the water. And all of our trainers have the cell phone app. I'm not going to tell you the name of it just to maintain conflicts of interest. But you can put your hands on this thing and it can send a rhythm strip immediately. So when Tony Bennett almost fainted in the NCAA tournament 2 years ago, I was in my living room. I was looking at his rhythm strip, our basketball coach, in case you didn't know. I was looking at his rhythm strip about 3 minutes later. So that was pretty cool. But I said to the trainer, you know, these things don't work when your hands are wet. And these are swimmers. So get a towel, be ready, get her out of the water. And I say, gotcha. So that's how we're making these diagnoses. So all of our trainers have this app. And so it's made the diagnosis of rhythm abnormalities much, much easier. She doesn't want to get ablated. She's still swimming. She wants to wait. So what are some of the things I've learned in sports cardiology over the years? I might want to just go over these. Beware the incidental finding. I mentioned this a little bit earlier. And then how can you accrue the necessary experience and exposure to become a competent sports cardiologist? And I mentioned this also, why do I hardly ever refer to the guidelines, especially when making participation exercise recommendations? Can valvular heart disease, congenital heart disease, superimposed upon athletic training amplify cardiac remodeling? You already saw an example of that today in HCM, which was very interesting. And what is the proper approach to stress testing? And this is one that's really an interesting question to me. Does the sports cardiologist need to have in-depth prior experience in sport to be successful? And I'd be curious what you all think of that, because I'll get into that. And then how can you get help with those gray zone athletes? And then we'll just try to fly through this. So remember our football lineman from this morning that had the very first ECG I showed, the middle linebacker? It's a good thing you didn't hold him out, because the kid won the academic Heisman this year, so I'm glad you let him play. But he goes off to the combine, and he damn near runs his GPA in the 40. That's how smart he is. That's how fast he is. But then I get a phone call. Something happens. And it's just this. So is the cursor up there? Yeah. You see this little flicky thing in the outflow tract right there? You say, Rich, it doesn't bother you, does it? Not really. I mean, you know, what is it? We're not really sure what it is. So it was in an unusual location. Is it an accessory chordae tendon? Is it got a septal attachment? What the heck is that? But this could have gotten him in trouble as an incidental finding. And I'd seen it, so it was Dermot Phelan. Were you there when Dermot did Cleveland Clinic? You know, Dermot? So he called me, and I said, oh, it's been there. Mike has had this all along. Don't worry about it. It's nothing. And when he came back, I actually, let me go back. I actually got my hand on the probe because I wanted to see what this darn thing was, whether it really was part of the mitral valve. And you can see, if you look at this clip here, you can see it's actually attached right down here, part of that papillary muscle and near the septum. And then here, I got my hand on the probe, and it actually showed that that false tendon comes across and attaches about 2 o'clock right to the antral. This is absolutely nothing. But it almost got him in trouble. And it could have impaired his stock value at the combine, which would have been really disastrous. And so that's one of the things I say about the incidental finding. Just be really careful, take your time, don't overinflate it, and be patient. Now, how about cardiology experience accrual? You know, we have written some core curricula, but that's not going to be enough. You can't just read a paper and expect to do this. And one of the things that nobody really talks about is that if you do have an opportunity to get into a college screening program, That's a form of cultural immersion. You know, if you've got 50, 60 college athletes there in one evening session, you're looking at those ECGs, if you're looking at the echoes, you're really going to get a sense of what's normal and what's abnormal, and you really can't fast forward that seeing an athlete every month or two. It's really hard to do. So if you want to do this, contact your local John Dresner or contact me if you want to come to a screening session. You can come and dive deep. Some people do them all at once. That's really hard, but you'll find it's really hard to get kids there too. And I worry about having it dragged out too long and having some kids screen and other kids still screen later in the year. It's a little bit of a risk medical legally just because you have a little bit of a different standard for the kids. And then think about other specialties you might incorporate. Personally, what I've done, because I've been in smaller markets, is I'm an adult congenital specialist, but also have brought in structural genetics with Matt, and we're a hypertrophic cardiomyopathy center of excellence, which is great for the gray zone overlap. And then I also have what I call a POAC clinic. Anybody know what that is? Rich, you don't know what that is? Plain old adult cardiology. Comes from like plain old balloon angioplasty. And I just don't think in this day and age it's wise to be someone with very few at-bats and pinch hit in this thing. I think you've really got to try to accrue the experience, and that's going to be a challenge. And so why do I rarely use the guidelines? This quote, there are few definitive data demonstrating either that strenuous exertion predisposes to a death which otherwise would not have occurred, or that withdrawal from competitive athletics will prolong life. That was in the original Bethesda guideline. And it really hasn't changed very much, possibly with the exception of ARVD or ARVC. But, and then we've talked about the paradox of exercise today. These recommendations are mostly based on expert opinion and not on data. So I'm not sure guidelines is really an accurate reflection of what they are. And I'll be honest with you about another thing. I'm not really sure a lot of them are that consensus-based either, because when you get into these committees, there's a lot of power going on, and certain personalities can influence the way things are written more than others, and it's not always a pure consensus. Now, maybe I'm wrong about that, but that's my sense. And then there is a mountain of evidence supporting the salutary effects of regular exercise. And if you look at the Italian argument, we're not seeing any deaths from HVM since we started screening. Well, yeah. Well, like I said to the coach of the kid this morning, I didn't say it to him, but he was real uncomfortable with shared decision-making and shared risk-taking with this young basketball player that may have had HCM, may have had hypertensive heart disease. I don't really want him happening. I don't want anything happening on my watch. And my response, well, then there's, so it's okay if he's, you know, in the backyard of somebody's house shooting baskets or playing a pickup game and something happens. That's okay. So it's a lot more complicated than we make it out to be. So we've heard a lot today about emergency action plans and things that are so vital to the survival of us. And I think what John said is just great, that there's 50% more of these people that we can help. And if we get it right, you know, one of the first examples of commotio cordis was a judo kid gets kicked in the chest, and everybody just stands there and looks down at him for 5 minutes. It's just hard to watch. So I think it's far better to spend your time and effort in shared decision-making and shared risk-taking and telling them about the data we don't have, as well as the data we do have about the healthy benefits of regular exercise. And then, you know, it's always important, I think, you know, I have a nurse that works with me every day in clinic, and I try to have her always there when I have these conversations, just so there's not just a medical documentation in the record, which I'm very meticulous about, but there's a witness to it that knows your practice patterns, know how you, because you guys know how patients walk away and they'll say things that are completely out of character that you would never do or never did, and your nurse or whoever's with you can vouch for you there. It's probably better to do that than just have your fellow there. I'll skip that. Now, we published this because I'd seen this actually happen. There was a Division I college swimmer with moderate, at most, a soft moderate aortic regurg. Not anything you would ever think about operating on. But he had LVID, an LV diastolic dimension of 7. And his local cardiologist was actually here in North Carolina, wanted him to have a valve replacement. He was 19 years old, and he was at Colorado Mesa University. He had just swam a personal best in the 400 IM at 6,500 feet of altitude. So that was a case of both volume loading from all the swimming and the aortic regurgitation. He did not need, and in a 19-year-old, if you put a tissue prosthetic valve in a 19-year-old, that thing can calcify fairly quickly. That process doesn't typically abate till after the age of 25. Kids will chew through prosthetic material because they're mineralizing bone still. So those decisions aren't that simple. And then we had a cyclist with tetralogy, Rich. He had moderate pulmonic regurg, not near as bad as the one you showed this morning. But he had a big RV, an RV of 150 mils per meter squared. You would think, well, he's got to have a pulmonary valve replacement. He was on the cycling team at Bucknell. And I said, well, how do you do? And he goes, oh, I do great. And I go, okay, well, when the road goes up, do you go to the front of the pack or the back of the pack? He goes, I go to the front of the pack. So it was really hard for me to reassure the congenital physician in this case that he didn't need a pulmonary valve replacement right now. Now, you got to be careful, though. So we had an asymptomatic master cyclist with severe aortic regurg. He could cycle about 18 miles an hour on flat ground without wind, and he didn't want to have surgery. He didn't want to have surgery. Then he got meningitis. That's a great way to detrain people if you want to detrain them. Give them meningitis. And his volume shrank dramatically by MR. Then he went back to training again, and he just, his doc called me. I said, well, I think it might help his performance. You don't want to just sit on this for too long. And he sat on it, and finally, his post-op EF is 45%, and he's no better than he was preoperatively. So there is a case of waiting too long where you got to be really careful. And then help with the gray zone. Take your time. As I showed this morning, make sure you're measuring compacted myocardium. You're not getting into the moderator band, into the trabecular patterns on either side of the septum or wherever you're measuring. And reach out. And try not to think about liability, but that's easier said than done. And this keeps you humble. So the kid I was talking about with the hypertension, the basketball player that I cleared, that hit the game-winning shot against us and all that, I get an email from his team doc like a year and a half later. Dr. Battle, I am sorry to inform you that our mutual patient, and he used his name, and I just about fell out of my chair backwards, tore his ACL, is going to be out for the season. So for those of you in sports medicine, be careful how you address your sports cardiologist because I almost had a heart attack over that one. And the other thing, and we had this with Igor today, a really good advanced imaging person can really help you. I can call Chris Kramer, one of the top MRI people in the world, and he'll look at an MRI with me for me within 5 minutes. I don't care where he is, remotely on his computer. And so it's really invaluable to have that. And this was what I was getting at with the T1 mapping and the extracellular volume with this group really showed that athletes who had normal values and HCM had abnormal values. And so I asked Chris, this was last week, I want you to go back on my basketball player that we think has hypertension, I didn't tell him that I don't think has HCM, and I want you to calculate his ECV. And he texts me back 5 minutes later, goes, it's minimally elevated, does he have hypertension? And that was like, wow, he didn't even know that he had bad hypertension. I said, yeah, he's had bad hypertension. He goes, well, that fits perfectly. Now, this isn't perfect, but you just need all the help you can get, and it's not always easy. And one other thing I wanted to bring up, nobody's talked about this today. When you're evaluating athletes for performance, the economy of exercise becomes really important. Now, if you're running or cycling, that's not such a big deal because it's very repetitive. You get tired, your form can suffer a little bit, but it may not break down completely. But think about skating or skiing, cross-country skiing, and that's one of the hardest sports I've ever done because you're employing tremendous amounts of force and the balance is so key. And when you get tired, you start to lose your balance and you start to lose your function. So it doesn't matter what your VO max is in that situation. And I think if anyone's read Boys in the Boat from, the crew team from Washington, what's called the swing, when they're in the swing and they're really hitting it, it's not about all their power, it's about their synchrony. And crew athletes rely on the 2,000 meter erg time, on the erg trainer. And that's like if you can break 7 minutes, a female college NCAA Division I rower, and I'll often bring them into the stress lab to look at that because that's what they're doing. They're killing themselves to get to that number and can be very, very difficult. So we've talked a lot about the Bruce protocol. I just think it's really important. Now, these erg trainers, by the way, they have wheels on them, so your trainers can roll them right into your stress lab and you can use them right there. So that's really important. And as I said this morning, abandon the nuclear rules. Let them exercise where they can get to their peak capacity, and don't have all this stuff about, you know, gastric shadowing and all that kind of stuff and all that. So tailor it to the athlete. There's Matt. There's my treadmill. You know, and the first time I did an athlete stress test, I didn't have my own lab. I went into the usual adult stress lab, and I had this kid running interval sprints. All of the technicians in this suite, there must have been 20 of them, came running down. What the hell is going on? Sounds like there's an airplane taking off in there. Because they had never seen anything like it. Never even occurred to them. And most treadmills that you have in your hospital will go 16 miles an hour max. And you have to often keep the button depressed the entire time, or it will default back to a slower speed. So you just can't simulate this. Now, this was a treadmill that could go 30 miles an hour. Unfortunately, you know, you guys got the Be Safe stuff going on, right? The Be Safe people came over, and there were no way to convince them that some kid wasn't going to fall off the back of this and hurt their head. So they took it away from me. But that was okay, because we had a basketball player. We had to actually raise the roof because we couldn't get him on the treadmill and fit him in the room. So we got a smaller one, but it's still adequate to do the kind of stress tests that we've talked about that are really important to reproduce that environment directly. And then finally, is prior experience necessary? You know, my former colleague in sports medicine, Danny Mystery, insisted that was the case because he had so many problems with cardiologists that didn't understand sport. And like I said, you just haven't had the same training as your sports medicine physicians that are so immersed in that culture. And, you know, we're not on the sidelines either, which, you know, is fine, but that's the way it is. And then the training history becomes imperative. So I get a question last week from a 64-year-old triathlete. Hey, doc, when I'm training with my crew, my heart rate is 25% higher than those around me. Before assuming this is a performance problem, you might want to do a CPET, but you need a better history. And you need to know something about swimming and cycling and running to figure this out. So it turns out he swims 100 yards on 2-minute intervals. That's okay. It depends how long he's fast he's going and how much he's resting. He runs about 8-minute miles with no issues. Cycling on flat ground, guess what his speed is? His average speed is about 16 miles an hour. So about half of Marcelo, you know, earlier today. That's not very fast. And then I asked him, who do you ride with? And he goes, well, do you ride with triathletes? No, I ride with cyclists. I said, are they hammerheads? He goes, yeah. I said, is this on flat ground or when they're going uphill? And he goes, oh, it's always on the climbs. So think about it. He's a swimmer. He's got all this upper body mass. What does a cyclist look like? They got no upper body mass. They almost don't even have arms, right? And so he's trying to pull all that weight uphill while they're just kind of cruising along. So this really doesn't smell like a performance compromise problem to me, although we're going to investigate it, and that's really going to happen later. Now, this was the very first American college learning pathway for sports cardiology in Chicago. And we were on the 3rd floor. And every time I got there, I saw the same thing, and I finally had to take a picture of it. Our sports cardiologist athletes, well, you tell me. Everybody's on the escalator looking at their iPhone. One guy's trying to go up the stairs, throwing up, third of the way up. The other guy looks like he's not going to make it. So this was just a spontaneous photograph that I took. So you know, I think there's a lot to be said about knowing a lot about sport. And if you're not an athlete, you got to figure out a way to learn it. And so you really got to get in deep. And then I'm going to come back to the whole ADHD thing briefly here, because this is the spot on Mont Ventoux. If you are a cycling fan, this is where Lance Armstrong and what was the pirate? The Marco Pantani, the pirate, the Italian, had all those duels. And this happens to be the spot on Ventoux where Tom Simpson died in a race in the Tour de France. He was a British cycling champion and he died in 1967. There's a memorial for him. His postmortem revealed a combination of amphetamines and alcohol. They had to drink, too, to get through this race. That's how hard it was. And there were no restrictions on doping at that time. These two characters, Francis and Henri Pélissier, were two brothers that abandoned the Tour in 1924 in protest, and they talked to a journalist, and they told him Henri was a champion of the Tour de France the year before, so he didn't even want to defend. That's how hard this race is. Takes a vial from his bag. That's cocaine for your eyes and chloroform for our gums. I don't know what the heck he means by that, but it's not good. And then in pills, you want to see pills, we run on dynamite. Okay, so we've got a situation where we're asking athletes to do something that's almost impossible, and they're looking for a competitive edge or some way to get through it, and we demonize them. Yet in the classrooms today, PE, I call them classroom PEDs. Now, there are some kids that have attention to, I'm not arguing that, and this is not a moral judgment. I grew up in the 60s and 70s, so, you know, I'm not making a moral judgment about this, but are really 10% of our children need to be on slow-release amphetamines to do well in school? And you know what? I know I'd have gotten better grades. I would have taken them if you'd given them to me. But I'm really worried about it because we've got college kids, they're taking too many at exam times, they're sharing them, they're stealing them. And now that opiates are going to be hard to get, I think they're going to come up with some more creative ways to abuse these drugs, and it really, really worries me. And I just don't know what effect these medications are going to have on people's brains over the course of their lifetimes. And when they're going off to their jobs, they're finding them they need to get a competitive edge. They need to take them to keep the competitive edge on their jobs. So I don't know. It's just a funny spot for me because I know growing up, every one of my friends, including me, would have been diagnosed with this if we took that simple test. So think about that. Oh, this is a shameless plug from American College of Cardiology for our meeting upcoming in Park City. If you really want to go deep, come on out there, but if you don't, that's fine too. I'm off the Leadership Council now, so I'm not going to give a talk, so you wouldn't have to listen to me. And this is the quote that's over all of our exercise facilities in Virginia. It's give about 2 hours every day to exercise, for health must not be sacrificed to learning. A strong body makes the mind strong. That's from Thomas Jefferson. And actually, one of the things that he did when he designed the rotunda was built a covered walkway exercise area, which is probably the first gymnasium in American architectural history, to try to make sure that the people were not only getting educated in their minds, but their bodies as well. So with that, I'll conclude. I hope I caught up a little bit, Jim. And thanks for your patience.